Hello. Today I'd like to talk with you about handoff communication. Shift report is one of the most critical times of the exchange of patient information in our day, and it requires a transfer of information from the outgoing nurse to the oncoming nurse during a very busy time. The research tells us that nearly 70% of medical errors or sentinel events occur in healthcare due to communication failures. So how can we improve communication at critical times such as shift report here at Northeast Rehabilitation Hospital? Bedside report is intended to engage our patients in this critical exchange of communication. It allows for an opportunity for the oncoming nurse and the outgoing nurse and the patient to share information, express any concerns, and to verify information regarding the patient's history and the current plan of care. Nursing research has demonstrated bedside report to improve patient safety, to improve the nurse-to-nurse communication and teamwork amongst nurses, and to improve patient satisfaction by building trust, reducing their anxiety, and most importantly, to engage our patients in their own care. It is our goal here at Northeast Rehab to continually improve nursing excellence and patient safety, and we are committed to putting the patient at the center of our care. When done correctly, bedside report leaves our patients feeling involved in their care and safer, and in fact, they are safer. We believe that both IPASS shift-to-shift handoff and bedside reporting, which you have all been working very hard at, will accomplish those goals. It is necessary for all of us to see the benefits to our patients and continue to practice and improve as we put these new processes in place for safer care. This educational video on IPASS bedside report has been created by your leadership team and will allow you to see what an IPASS handoff done at the bedside looks and sounds like. The team has brought humor and learning together, so pass the popcorn, here we go.
Aids and therapy. Have you had it before?
Yeah, I think I have. I can look at the cardiacs.
So you can read the cardiacs.
Yep.
Yeah, he's had an uneventful day.
Okay.
Vital signs were fine.
Okay.
To be honest with you, he was in therapy all day. I hardly even saw him. I gave him his meds. He did get some blood sugar before lunch. I gave it to him. He got a sliding scale.
All right.
But I've had a crazy day.
Okay.
And we got like, what, 6 other patients to
Okay.
go through?
Let's move on. Let's go.
Okay.
Yeah, I can look at the cardiacs.
Okay. All right. She's 44. She had back surgery following Lammy, had some respiratory failure.
Alright.
She's on IV Vanco for pneumonia. So I'm not quite sure what time we have to give it, but it's given on your time. She's also going to have some labs drawn then too, so make sure that you follow up with that. We're leaving her O2. Today she had a drop in her stat, monitoring her back incision. She's got some drainage there.
Do you think you could turn on the TV over there?
Excuse me?
Could you get her some headphones maybe?
Sure. Yeah, we'll get her back.
Yeah, well, we're in the middle of
She kept me all night.
We're in the middle of report right now.
All
Okay,
night.
so we'll get to
She kept me up all night with that TV.
Anyway, continue.
Okay. Continent bowel and bladder, moved her bowels, and pain issues. So she's due for pain medicine, I think, by 4:30. Okay?
Yep, sounds good.
Okay.
Alright, let's get to the next one.
Okay, yeah, we'll give her some headphones.
Okay, thanks.
You got it for me.
Okay, so Lisa Lovely, that's bed 2. She's 44. She was admitted back
I
here
know
on the
her.
16th.
I've had her
Okay.
before, yep.
So pretty uneventful day. Monitoring her back incision.
Looking for Sam Smith.
Excuse me, brother. What?
Yeah, you just check out the desk. We're doing
Yeah,
report
the secretary at the desk can help you with that. All right.
Jeez, people don't even think.
She's on oxygen. We're trying to get her off of it. She takes oxy for pain.
Well, she smokes, right?
She's a smoker. Yeah. Yep. Alert and oriented. Take her meds whole with water. Pretty uneventful day. Didn't really have to do much for her. Like I said, I changed the dressing, so you might want to look at it because there was a lot of drainage. Oh, and I put a call into the doctor, so he might call you back.
All right, great.
Okay. And they have IV Vanco tonight, so there is a trough.
And you didn't get the result?
No, it has to be drawn on your time. Oh, and the CBC and the BMP was added, so and the doctor wants me called, so make sure you call. Great, great.
Thank you, Renee and Robin, for portraying how not to do bedside reporting. They had done a great job at demonstrating that bedside reporting needs to be in the room at the patient's bedside and not in the hallway. When we're in the hallway, we're not engaging the patient and including the patient in that report, or checking with the patient if there's any needs such as toileting, pain, positioning, if there's anything outside of their reach or not on their bedside table. While they're in the hallway, they risk sharing PHI, or protected health information, with other family members, passers-by, people that shouldn't be hearing that bedside report. They weren't very thorough or engaged in the bedside report process. They didn't utilize IPASS and talked about the illness severity as they should have. Robin was also on her cell phone, so we want to make sure that we're mindful not to have our cell phones out during report or when we're in the patient room or hallway, because it really portrays us as nurses not in a professional manner, but more focused on our cell phones, and it's unprofessional at times. So there's a time and place for cell phone use, and that's our break time and in our break rooms. If you are utilizing a cell phone to look up information, that's different, such as drug use and interactions. So please be mindful of that. Something that Renee and Robin also should have done was move themselves to the bedside. Being out in the hallway is never appropriate for bedside reporting. Some of the key points we want to be mindful of during bedside reporting are positioning. Never have your back to the patient. Introductions. Both nurses should greet the patient by name. The outgoing nurse should introduce the oncoming nurse. Outgoing nurse should manage up the oncoming nurse. Such things that should be passed along are phone calls that are expected from doctors or surgeons, any pending labs, the whiteboard. The oncoming nurse should update the whiteboard with his or her name and that of the LNA. Involve the patient. This is critical to a successful report. Clinical information. Use IPASS to standardize the relay of information. We also want to be aware of our body language. Body language and negative comments can be perceived by patients and families or overheard, and it gives them a negative feeling of their stay and their comfort level with our nursing team. So we want to always be mindful to keep our negative comments to ourselves. I think they did a fantastic job of showing us what we shouldn't be doing. Now let's take a look at some examples of what bedside reporting should look like.
Hey Lisa.
Hi.
I wanted to introduce Robin. She's going to be taking over for me for tonight.
Nice
She's going to be
to
a
meet you.
311 nurse. Robin, I wrote your name on the board already.
All right. Angie will be your LNA.
Okay.
And this is?
This is my sister. She came in from out of town.
Hi, nice to meet you. I'm Renee.
Meeting you. Hi, Renee.
Hi. So we're going to give bedside report,
Okay.
and we, really interact with the patient, give some information. We're going to ask that you step out at this time,
Okay.
and then we can call you back in when we're done.
Okay.
Is it actually okay if she stays?
Yeah, that's
It's
fine.
okay if she hears it.
Yeah, absolutely. You can stay. When we go to give report on her roommate, we're going to have you step out though.
Okay.
I'll let you know
That
when
makes
the time
sense.
you can come back.
Okay.
Okay?
Thank you.
All right. So let's talk about your day today. So one of the things we're watching with Lisa is that, she had a laminectomy done, L3 to L4 due to spinal stenosis.
Mm-hmm.
You had that done on, what's the date again?
It was 2 days ago.
2 days
Well,
ago.
I got here 2 days ago.
Okay. And then after surgery, she developed some shortness of breath and up having some respiratory failure, needing to be intubated. They put the tube down for about 12 hours. And now, since then, she's stuck on oxygen, and she's not on at home. So the areas that we're watching is that she's got a lot of drainage from her incision, and she did have an episode today where she dropped in therapy. We're trying to wean her off the oxygen, and when they had you off of it walking, your sats had dropped down. You're 94% on the 2 liters, she dropped down to 90, so we had to put her back on the 2 liters. So those are areas that we're watching. Let's see, the other areas today, she is on IV Vanco to treat her pneumonia, so she's on 1 gram. You're on it twice a day. And she's got a head block here on the left. And sight looks good, it was benign, she's had no tenderness, it flushed fine. She's due for her IV Vanco at 6 p.m., but she's going to have a trough with a CBC and a BMP, so they're going to draw some blood work. They're going to check your levels for your Vanco and also do some other check, like your, see if your, what your white count is, just do a basic panel.
Okay.
So those are going to be done. I called the lab at 5:30, so just make sure that those are done before you hang that.
Also, I'll be letting the doctor know about those results, so if there's
Thank you.
anything that's out of whack, we'll let you know.
Okay. Let's see. The other thing is that your pain. You said we've been trying to keep really on top of your pain today. You reported it at about an 8.
That was the highest that it got.
Okay.
But after the medicine, it went down to about a 3 or a 4.
And she's on oxycodone. She can have 5 to 10, so she took 10 milligrams about 12:30, and also gave her 5 milligrams of Flexeril. I think it was about 10:30. She can have that every 8 hours. So she's due next at 4:30.
Yep.
So assess for pain meds there. And she's on Venodyne. She's not on any chemical DVT prophylaxis because of the spine surgery. So we talked about the importance of keeping those on to prevent any type of blood clots.
Yeah, they're really warm.
Yeah.
They can be. If we take off your socks, it might help you feel a little cooler.
The other thing is her back incision. So her incision has been having some good amounts of drainage to it, and we've been having to change the dressing probably about once a shift. I did it last about 10 this morning. I did put a call out to your surgeon, Dr. T, just to notify him. We want to make sure that he's okay. Doesn't look like any signs and symptoms of infection, but we want to be safe. So Robin, hopefully he'll be calling back a little bit. His office said he was in surgery and he'd be out later.
Okay.
So we want to look at that. Her rest of her vitals have been fine today. Her lungs are dim. They did note you had some coughing on 11 to 7. So also when you call the doctor for those labs, if maybe you can ask for an as-needed cough syrup if you have any coughing
That would be
overnight.
good. Also, I dropped my incentive
Oh.
thing.
Spirometer?
Yeah.
We can get you another one.
Absolutely. Okay. The other thing we want to talk about is she does have a nicotine patch that's on. So we have it on your left. Yeah.
Okay.
So she is a smoker. We say about a pack a day prior to your surgery.
Yeah.
So we talked about whether or not hopefully this will cease it and she'll go back smoking or not. We're hoping no.
We'll see.
We'll see.
We'll
Yep.
see. Let's just say I really want to come off of oxygen before I go.
Yeah.
Well, I'm sure we can manage that.
Yeah.
But we would like you to give some good consideration to not smoking. It's one of
I
the
will.
best things you can do for your overall health.
Okay.
So we did talk about if she did smoke that she has to take that patch off. That is going to be very dangerous. Deadly to smoke with that on. Let's see. She has a PRN of epidural treatment. She has not needed that. Bowels. When did you last time with your bowels?
This morning.
This morning.
Yeah.
Great. And you've
And
been
it was
avoiding
okay.
It was
bowels.
okay.
No,
Yeah.
it wasn't hard. Because sometimes these heavy-duty narcotics that we use for pain, although they handle the pain very well, they
Yeah.
can definitely contribute to constipation.
Okay.
We don't want you to get to that, so we have things we can put in place if that starts to happen.
Okay.
So
It hasn't yet.
Okay. Yeah. Did you think of anything else that I might have missed?
No.
No. Okay.
all right, then someone will be back in about an hour to check on you, see if you need anything, and you let me know about your pain. We'll try
I
to
will.
keep
I
on
think
top of it.
I think I will definitely want something at 4:30 because it was a long day with therapy. They keep me really busy here.
Okay,
We'll
I'll
say
check
I have
on that for you.
So-
Bring
long
that
day
back at
coming up.
4:30.
Okay. So just to recap the things that
Yes,
we talked about
so-
for you to do tonight.
We talked about how your goal is to get off the oxygen, so we want to promote, your pulmonary, your respiratory health. So you want to cough, deep breathe, and more importantly than anything else, you want to move around.
Okay.
So we want to stay out of bed as much as we can
Okay.
and walk as much as we can. And also we're going to stay ahead of your pain. you're gonna let me know what you're feeling, when you're feeling it, and we do that as needed. We're gonna keep an eye on the IV site. We're going to draw a trough level and CBCBMP, and I'm going to call Dr. Ty with the results as well as an update for him on the amount of drainage from the incision. Did I miss anything?
No, I think that's about it. And then just the PRN cough syrup.
Oh, yes, when I call him. Thank you.
All right, Lisa, it was nice working with you today.
It's nice to meet you.
And maybe I'll see you tomorrow. Someone will be back probably in about an hour approximately to check on you. But if you need anything in the meantime, give us a ring.
I will.
Okay.
Thank you.
Thank you. Nice to meet you.
Nice meeting you.
Have you had Mr. Spade before?
No, I haven't.
Okay. So Mr. Spade, so he's a watcher.
Okay.
Just so you know, things that we're watching is he's really on strict INO. He had some short-term dialysis in acute care hospital, which he hasn't had it here, but we're really watching his weights and his INO. And he's got some chronic edema, and he hasn't moved his bowels in 3 days. So Mr. Spade is 63. He was admitted to us on the 28th after being found on the floor at home. He was on the floor for 4 days from a fall. He didn't suffer any injuries from the fall. He lives alone. He suffered rhabdomyolysis and had acute renal failure, which required dialysis.
Okay.
He does still have a testio in his right chest wall. Dressing's intact. So it's been like 10 days since he's had dialysis. Has a history of AFib. He's on Coumadin. He's therapeutic right now at 2.2. He does have a recent DVT in his right lower extremity. He's also a type 2 diabetic, and at home he'll use his oral agents, but because of his renal failure, he's now on Cytoscale Novolog and Landis. So we've been working with that with him.
Okay.
Put it for his nursing goals.
Okay.
So he does have a pen. We did it this afternoon with lunchtime, and he did pretty good.
Okay.
He was 172 before lunch, so he required, I think it was about 3 units of insulin, and he was able to give himself it with
Okay.
some like cues. He needed cues. What else? His skin is pretty much intact. He's got no redness or open areas, but we're encouraging him to turn side to side because he's at high risk because of his edema and stuff. And we're offloading his heels. He a lot of times pulls the pillow out, so we have to keep going and just re-educating him about that. He does complain of back pain and some right lower extremity pain. So this morning he was about a 7, and at 1 I gave him 10 of Oxy with good relief. He came down to a 3. Like I said, we've been elevating his legs. This morning his lower extremities were trace edema, and about the last time I checked, with the last rounds, he was about a +1, just from being up in the chair all day. And his appetite has been pretty good. So for his strict INO, he's had about 1,200 cc's in for the day, and it's in the INO, and he's had about 950 cc's of output. We've also doing daily weights, and his weights have been pretty stable in the last 3 days. Today he was up a half a pound, which I'm just watching. Like I said, his blood sugars were pretty good. He was 156 before breakfast, 172 before lunch. He has been ringing appropriately, but he is really deemed a high risk just from his fall risk, so we're continuing with the bed and chair alarm, just really encouraging him to use the, excuse me, Quelle. What else? He's continent of bladder. He has been using the urinal.
Okay.
But it's his bowels. So he hasn't moved his bowels in 3 days. His abdomen is soft. He's not really complaining of anything, but it is distended.
Okay.
So
have you given him anything?
he does not have any. I have not given him anything. He
Okay.
has orders that if he doesn't go by 6 p.m., that you'll have to give him medications.
Okay.
And a suppository.
Okay.
Let's see. Anything else that I might have? Let me give you an action list of what you are to do for tonight. So we need to continue the strict INO. Also, he had labs. I didn't mention that. So he did have labs today. He had a BNP, and we need those to be called to his nephrologist, Dr. Rao. Okay. So there's some concern that depending on his kidney function, he might have to go back on dialysis. Also, please give Dr. Rao, she wants his tallies of his INO and his daily weights. And like I said, if he hasn't moved his bowels by 6 p.m., he has orders to receive, I think, his lactulose and then a suppository. And then when you do his insulin tonight, if you can continue the teaching with the Novolog and the Landis. and just elevate his legs for the lower extremity edema.
Okay, sounds good. So let's just go back over this. So he had a fall at home, he had rhabdomyolysis, he had acute renal failure. He had been on dialysis but has not been on for the last 10 days. He has a testicle on his right chest wall. This dressing is intact, so I will check on that dressing later. He's on Coumadin for his AFib, and his INR today was 2.2. Okay, and he also has a DVT in the right leg for that. And it's on the Coumadin also. He's diabetic, and we're going to check his blood sugars at meal and at bedtime, and he needs to continue to learn his insulin.
Correct.
He had some labs drawn, and I will follow up with Dr. Rao regarding the labs, and she would also like a tally of the INO and the weight.
Correct.
Today's weight, which he's only up about a half a pound, is that what you said?
Correct. Yep.
Okay, we'll continue on the INO and monitor his legs for the edema, which you said he only had a trace earlier.
Yep.
Okay.
And it's up to a +1 now, since it's later in the day.
So we'll check on that. And then he needs a suppository if he has not had a VM by 6 p.m.
Correct.
Is that correct?
Yep.
Okay, anything I missed?
No, I think that's it.
Okay. Let me just change the list here.
Alright.
Okay. And put that down there. Should we add daily weights to the nursing goal just as a
Sure.
little reminder on there? Okay. Yep.
Alright.
Alright.
Awesome.
Sounds good.